Americans than it is among non-Hispanic whites and Asian Pacific Islanders. So this is almost certainly merely a reflection of the fact that we're not doing as good a preventive health job among African Americans and Native Americans. And this means that we're not getting members of these populations adequately screened and adequately treated. And you can put up similar slides looking at outcomes of treatment in different ethnic backgrounds according to people all getting treated at the same stage of disease, and the outcomes are poorer in people from African American and Native American backgrounds. And that's something that the whole society has to focus on and do something about. But it means that we've got a very important job to do here, locally, in the Navajo Nation, to try and get people screened properly for the common cancers, including colorectal cancer. Next slide. And this is, I'm not going to go through this in any detail, but this also can illustrate a very important general point about most of the common cancers, certainly all the cancers that I'm talking about this afternoon. And that is that for all cancers, we know that there is a proportion of those cases of a particular cancer that are going to be more common in some. This is nothing to do with ethnicity or racial background. This is to do with family, what we call family history. And so one of the really important things that anybody here this afternoon can do is when they go home and they talk to their family or their friends, they make sure that all of those people know that if you have a parent or a sibling, brother or sister, or even a child, but really a parent or a sibling or an aunt or an uncle who's been diagnosed with a cancer, then that may mean that you yourself are more likely to get that cancer than would be somebody who doesn't have a close relative who's been diagnosed with that cancer. So it's very important that we all know our own personal family histories, okay? So, you know, I happen to come from a family where there's been, unfortunately, a lot of breast cancer. So that means that all the women in my family, they need to be aware of this. And for most of them, it means that they're going to need to get screened early, starting at an earlier age. They may need to be getting screened in different ways. So it's something that everybody should know. So remember, we're all enormously proud and we belong in our families, but we also want to know if there are any particular risk factors in our families that might make us more likely to get colon cancer than somebody who doesn't have a family member who's had colon cancer. Next slide. And so I'm hammering away, I hope, getting at the idea that number one, we can do something to prevent ourselves from getting some of these common cancers. And that usually actually involves what I'm going to spend the rest of the next 10 minutes or so talking about, what we call screening. That is generally looking at people who don't have any symptoms at all, do feel healthy at the moment, but should be getting some regular kind of a check to see if they do have an early form of a common disease, a cancer, that has not yet caused any symptoms whatsoever. It doesn't mean that you shouldn't neglect, if you develop symptoms, if you're in my neck of the woods, so to speak, your bowel habit changes, you see blood with your stool, that's something that you should report to a physician straight away. But what we would like to do is to be able to check people out before they ever get to that stage of having any symptoms and do a screening test. And this is just pointing out a conservative estimate for the whole of the US, that if we were to implement screening as is recommended, and unfortunately the situation is that not nearly enough of the population is getting screened, but if we were to implement screening fully, then that, at a conservative estimate, might save up to 19 or 20,000 lives a year. So that's a lot of people dying. So we need to get screened. Next slide. And when it comes to the colon and rectum, the large bowel, there is an array of different kinds of, and I'm not going to go through these in any detail. So you can basically take a look in there. You can take an instrument and you can actually poke it up from the South Pole and take a look inside of the rectum and colon. And so there's a flexible sigmoidoscopy, that's a short instrument for doing it. And then there's a colonoscopy, that's when you go all of the way around the colon. There's a new kind of an X-ray procedure that I'm going to talk about a little bit in a moment that actually doesn't involve sticking any instrument inside of you. It's like a special kind of CT scan. Some of you probably have a CT or an MRI scan. And then you can actually get stool samples, and you can test those stool samples to see if there's any blood in the stool that shouldn't be there. And if there is blood in the stool, then it's not absolutely the case that would be coming from a cancer, but cancers do cause blood being shed into the fecal lumen, as we call it, and so blood does show up in the stool. So you can test stool and see if there's blood that isn't visible to the naked eye, that shouldn't be there and has got there by coming from a tumour. And there are different kinds of ways that you can test stool. I won't bother about that. Next, please. This is really like the old days. You remember Tim when you used to say, next slide? I think Tim and I are old enough to remember those days. Anyway. Again, I'm not going to go through this slide in any detail, but it also, I think, brings out an important point that there has been a sea change in a lot of ways during the course of my medical career. One of them, and there are most of them for the better, and this one is particularly, I think, for the better, and that is that patients, I'm a patient too, I'm not always a physician. We as patients are getting much better informed, and we're learning to ask tough questions. And I only put this up because this is a paper that came out in the Annals of Internal Medicine at the beginning of this year, which has set the cat among the pigeons in a major kind of a way. So I've already mentioned a colonoscope, which is an instrument that you can look all the way around the colon with. And it's being recommended that people get checked out with a colonoscopy every few years. And the supposition has always been that if you do that, inevitably you're going to diagnose those polyps, and you're going to remove those polyps, and you're going to diagnose those early cancers that have actually got a bit beyond the polyp stage, and therefore, inevitably, you're going to get rid of colorectal cancer. Well, it turns out that we have to be careful, and we have to do good studies to find out. And really all that's being said on this slide, if anybody wants to go to the literature, you've got the citation there. But what this is saying, this is from a very large study from Canada, where they collected data on colonoscopies across the whole population of Ontario over a period of years. And the bottom line is that evidently in this population, having had a colonoscopy did very little to stop people from dying from colon cancers on what we call the right side. So the colon comes up from here, your appendix is down here, and it comes up around and loops all the way down. Most of the cancers are more of them are on the left side over here, but there are also plenty of cancers on the right side. And it turned out that having had a colonoscopy didn't prevent people from getting cancer on the right side of the colon and dying from cancer on the right side of the colon. Now, this is set about an unseemly food fight, and gastroenterologists are fighting gastroenterologists, and people are looking at the data and saying, well, it's a Canadian study, and therefore they don't know how to do colonoscopy, and there's all sorts of bad stuff like that going on. But there is almost certainly more than a germ of truth in this. And so what this is saying is, yes, science is what we call an iterative process. We do what is the very best with the data that we have at the moment, but then we collect data and we ask questions and we check things out. And so it may be that we've got to do better with cancers that are going to arise on the right side of the colon. So that's why I put that. Next slide. Next slide. Okay, so now on to 4 different forms of screening again. What you're looking at here on the right panel, again, this is what you see when you put a colonoscope in there, and the top right-hand panel is a cancer. You can see it bleeding a little bit. And then that thing hanging down there, that's actually a large polyp, which is clearly on the cusp of growing to become a cancer, but actually we can remove polyps like that. And what we do with a polyp like that is we have another channel in the so we've got this black snake that we're looking up into the bowel with, and we can see it, and we also have channels, and so we can pass a wire through one of those channels, and then the wire in fact has a loop. You can open the loop, and you can put the loop over the polyp, and then you can bring the wire down over that stalk, and then you can tighten that stalk, and then